So I actually did this before, and I got to be the scientist the first time I did this, but now I get to be the clinician. So my job description is actually both. And is anybody in medical school here? Any MD students here? It's a very rewarding career pathway if anybody's interested in it. So I do probably 75% of my time I spend doing research, and about 25% of my time I end up seeing patients like Rick, who's agreed to come here with us, and the rest of the time I end up giving talks like this. So I'm talking about cardiorenal syndrome. I'm a nephrologist, a kidney doctor, and a lot of the patients we see with kidney disease have heart disease. And interestingly, a lot of patients who have heart disease also develop kidney disease. And probably over the last 5 years or so, this intersection between these two organ systems have become more apparent, and there's a lot more research. And Dr. Dickow after me is going to talk a little bit more about some of the basic aspects about what's going on in these patients. So I'm going to start with Rick, and I'll get you to come up here if you want, if you don't mind. So I actually was just doing clinic this afternoon and saw Rick, so he thought he'd get out of this and wouldn't be able to, would maybe be able to miss and not show up, but I told him he had to. So I first met Rick in 2009 December, and he was past history had been really diagnosed with diabetes, but that was only a short time before, maybe 6 months before. So a very short history of diabetes, but he got sick, and it looks like he got sick in October with H1N1. And if you remember a couple of years ago, there's this big influenza outbreak of H1N1, and it seemed to pass and nobody really got sick. Well, here's the guy who got sick out of everybody. So you were in the ICU, and the notes say, this was before I met you, the notes say you're in the ICU for about 10 days, probably intubated on the ventilator. And just as a first question, do you remember any of that?
Quite a bit.
Because I've read various reports that some people who are in the ICU have no memory of that at all, and some people remember parts of it. So was it out of experiences in your life, how does it rank?
Well, it was definitely different. I was in ICU for 14 days. The first 11 days I was in an induced coma. They were taking blood out of my lungs, so it's the first 11 days I don't remember a thing. It was the 4 days after they brought me out that I remember.
And do you remember still having the tube in your throat?
I still had one of the tubes in my throat, and I remember being strapped down.
Right. And do you remember any of the doctors or medical students or anybody else talking to you?
I just basically remember the nurses that were 24/7 with me.
Okay.
Because they were talking a lot. The doctors were in and out. I'm not sure who it was at that time.
If anybody has questions for Rick from the audience, he charges about, $1 a question, but he's more than happy to answer anything you've got. So after your ICU, they sent you home, is that right?
Yes. 14 days later, I was released, and I was having a little bit of problems breathing, but I thought that was because of the lungs were still recuperating and all that. But I was getting shortness of breath and stuff like that, so I just thought that was part of the process. And then, do you want me to get into the...
Sure. So before you ended up back in hospital,
Yes.
that's when you actually went back to work.
Yeah, I actually never stopped working. I'm self-employed. I'm a financial advisor, so my time's pretty flexible. But what I also do is standardized patient here. And I've been doing that for 9 years.
So for anybody, for those who are interested in medical school, eventually you're going to, once you get into medical school, you'll meet people like Rick who stand in for real patients and who are very highly trained, in fact, and have various symptoms and histories and things like that. And so it's a big program here at McMaster, the standardized patient program. And so Rick will stand in as somebody with psychotic syndrome or
Anything, yeah, multiple.
kidney infection or whatever, whatever you want. So what happened during the session?
Actually, I was doing what they call a warm body, and one of the doctors will be actually teaching a class on certain things. In this case, it was kidney. It was kidney inspection, so they were doing kidney inspections on me. I think there was about 8 students in this class, and basically halfway through it, I started to lose my breath and got real dizzy, cold sweat like, and I kind of, in the middle of the procedure, I told her to stop, and I sat out the side of the bed, and I guess it was Dr. Molina at that time, and she basically said,
Off you go.
we gotta go.
So you're supposed to be modeling
I'm supposed to be modeling a
a
patient.
kidney exam. And
Exactly.
the students are going, wow, that's
Yeah.
the best modeling of pulmonary edema I've ever seen.
Yeah, here I
could
go.
hear crackles and his JVP was up.
Yeah, next thing you know, I'm having these multiple heart attacks on the bed.
So you made it to the emergency room.
They rushed me off to McMaster's emergency, and that's the beginning of the.
And then to the general. And
Once I was stabilized, I was here for 3 days.
okay. And then at the general, that's I saw you before you were going for your open heart surgery.
Yes.
So just going over the history here. So we have the H1N1. The records actually show that you had a mild heart attack while you were in the intensive care unit. So
Well, that could have been. Yeah.
So, but this subsequently developed congestive heart failure. That happened in front of the medical students who probably stood there going, So down at the general, they did an angiogram. 2 of the coronary arteries were blocked, and the mitral valve, which is the main valve between the left atrium and left ventricle, was wide open. So
Yes.
one of the valve leaflets tethers to the muscle in the left ventricle, and it had pretty much come loose. So the blood was just not, it's supposed to stay in the left ventricle and not regurgitate up into the left atrium, but it was just wide open and regurgitating, and that was from ischemic disease. So you developed an acute congestive heart failure because of the mitral valve disease, secondary to ischemic heart disease because you have 2 vessel disease. Yep,
Oh, I was going to ask a question, if you don't mind.
sure.
I was going to say, your history of H1N1 seems pretty important. Did you have any sort of like lifestyle changes after this traumatic event?
Actually, it hit me so quick that I couldn't really do anything about it. My son was in Toronto having a party at the one of the kids that got sick, the original kid that got sick in Toronto. It was a Halloween party, and he came home late that night, so I didn't see him that night. But the next morning, I had some contact with him. At 4 o'clock is when I passed out. I actually passed out, and my son put me in a cab, and I was in general. And that's when I woke up 11 days later.
Afterwards, like that traumatic experience, did that change like your sleeping patterns?
Yeah, quite well. It did. Yes, it did. Good catch. To this day, I don't sleep in my bed. That's just something that happened. I just don't feel comfortable. When I tried after, and I just felt short of breath, but for no reason, because I don't have that. But I don't know. I think just psychologically something happened. So I still to this day don't sleep in the bed upstairs.
So where do you sleep, like on the ground or?
No, I sleep in another room.
Oh, then
But for some reason, I won't sleep in that bed. I don't know why. It's just, I couldn't sleep. 2 days I tried and I just couldn't sleep.
So, any other questions? So
Sorry,
after,
did you get sick often afterwards? Like you get sick often?
No, actually, I probably get sick less, but that's something really conscious. I overdress in fall because that's when I would catch the normal flus, and I haven't gotten flu shots. I was recommended not to take flu shots after the H1N1, so
really?
yeah, and again, whatever, you know.
Rick also has a small dislike of needles, so.
Yeah, don't even talk about needles, I get freaked out.
So just about about the kidney function, because this is really why we're here. So we've got the setting of a younger fellow with this acute heart failure, mostly due to this valvular abnormality. And when I met him, you can see that his serum creatinine. So apparently his kidney function was normal from February earlier that year. And I don't have any documentation of this. This was sort of passed on from a diabetes doctor who had seen him in Toronto earlier. But when I met him at the Hamilton General Hospital, you can see his serum creatinine was 250 micromoles per liter. Now, as most of you know, the kidneys are filters for your blood. This is a handy blood test we use to tell us how well the kidneys are filtering the blood. This should be about 80. In somebody's Rick size, it should be between 60 and 80. So this stuff is not getting filtered out of the blood, so his kidneys are functioning at a lowish level, quite a low level when I met him in hospital. His urine actually has 2+ protein, 3+ blood. We did a 24-hour urine which had 2.34 grams of protein per day, and we did some other blood tests. And I think there's two main issues, and I don't know if I have them. Oh, so here's his a little graph of his serum creatinine. So this is back at the time, I'm presuming it was normal sometime back in 2009. And you can see what happens when he has heart failure. So he's coming in with an episode of acute heart failure, and the kidney function just goes all to whack here. So I think that's the 250 here when I met him, and then he went for heart surgery, and the creatinine went up over 300 at one point. And then once the heart failure part of it was fixed, so he had a 2-vessel coronary artery bypass surgery, and they tightened up that mitral valve with something called an annuloplasty. So once the heart failure is fixed, the creatinine came back, not down to baseline, but it came back to a more tolerable level around 200. You can actually see that since then, there's been a progressive rise in the decline in the kidney function, rise in the creatinine. So there's really two things going on here. There's an acute change in the kidney function at the time of the heart failure. Underlying all this is some sort of chronic kidney disease, which is getting worse over the course of the 3 to 4 years that I've known Rick. Yep?
Often one of the critiques of using creatinine is that patients will have different baseline creatinine depending on their age, weight, muscle. Like for Rick, for example, can something like change in, I guess, muscles or like density or like weight?
Yeah, it's really odd. If you had met him back in 2009, Arnold Schwarzenegger, Rick Miyazaki, they looked identical. And you can see what's happened. No. So you're right. Creatinine is a very rough measure. We can use a calculated formula that we use in large populations, an MDRD formula, for instance, to come up with a more accurate measurement. But we're still, there is still some 30% variability. But I think the other thing is, though, following it longitudinally is helpful because that shows you the trend. So the kidney function is clearly getting worse there. So just to finish up, Rick smokes, which is bad. And here's some of the medications he's on, blood pressure medication and aspirin a day because he's had heart disease, anti-cholesterol medication because he's had a heart disease, and medication for his glucose, also some iron and some vitamins. And interestingly, he has a brother who's on dialysis, and that's correct, isn't it? He's since passed away. I'm sorry to hear that. But he was on dialysis with long-standing diabetes, is that right? But it sort of brings up two issues, which I'll get to in a second. So this is just blood work. I think I I've asked Rick to do blood work once a month because Rick is now actually on peritoneal dialysis. So we've started him about a month ago on peritoneal dialysis. So he's supposed to get blood work once a month. And he's a very compliant patient. So I think this blood work was from, July, June, something. So much for the monthly blood work. But so the creatinine's still heading up and is worse. Phosphorus is quite high. That should be cleaned out by the kidneys and isn't. Hemoglobin A1C is almost absolutely normal. So that's a measure of sort of the 3-month running average of your sugars. And that's very good. So as far as diabetes, it's either not there or it's very mild. And the cholesterol is actually quite good as well. And you can see the LDL cholesterol, which is associated with atherosclerotic disease, is actually on the lower side as well. So as far as risk factors, the traditional risk factors like diabetes and LDL cholesterol really aren't an issue for Rick. So he started on peritoneal dialysis, which is a type of dialysis we do in about 20% of our end-stage renal disease patients. And so the two main issues are, the first thing is, which really doesn't have anything to do with cardiorenal syndrome, I still don't know what kidney disease Rick has. So we sort of said maybe it's diabetic nephropathy, but he doesn't have a lot of diabetes and not a long history of diabetes. His brother was on dialysis, so it makes me think whether there might have been a chronic glomerular disease because he had blood and protein in the urine. IgA nephropathy is on the list. Something like Alport's is a familial condition that people can get, but I still don't know. And I went through my chart to see why we hadn't figured this out, and I saw notations, we'll plan for a renal biopsy. Patient didn't show for renal biopsy. We'll plan again. So we tried several times to get a biopsy to get a final answer, but unfortunately we didn't. In Rick's favor, though, none of these things are really treatable. So I think whatever we had found, we wouldn't have really been able to intervene to that extent. So the second issue that's really important to what we're talking about is the cardiorenal syndrome. And there's two parts to this. There's the first part where the heart went into a tailspin and the kidneys went off. So that would be a cardiorenal syndrome. So that's a kidney disease that occurs in the setting of heart failure. And the second is what Rick's experiencing now that he has renal disease with known underlying heart disease. And so that's sort of renal cardiac disease. So there's sort of two manifestations. So I'm going to briefly run through definitions of cardiorenal syndrome, some of the epidemiology and potential treatment, of which we don't have much. So here's some bright person has classified cardiorenal syndrome in 4 different types. And there's actually a type 5 that somebody's added in here. So the big distinction is, as I was saying, whether it's renal failure or renal disease that occurs in the setting of heart disease or heart disease that occurs in the setting of renal failure. And so type 1 and type 2 are, type 1 is an acute change in the kidney disease in the setting of an acute change in the heart disease. So that's an acute cardiorenal syndrome, and this type 2 is a chronic change in both of those features, but in the setting of somebody who has chronic heart disease. So that's really the cardiorenal part of it. And then there's also the renal cardiac part, which is really worsening of kidney function, which is associated with kidney disease, both acute and chronic. Type 3 is kind of thrown in there just to complete the circle, but rarely we see that. Most of our patients either have type 1, type 2, or type 4. They throw in this type 5 to say that somebody had, for instance, amyloidosis that affects both the kidneys and the heart. We'll put them in that category. So, and just thinking about Rick's presentation, he had type 1 back in 2009 when he presented, and now he has type 4 in the setting of chronic kidney disease and now having underlying heart disease. So just schematically, on the left side is patients with chronic renal failure, and on the right side is patients with congestive heart failure, and then we can say whether secondarily to that they either get heart disease or renal disease, and this would be the type 1 or type 2, acute or chronic, all the way over to type 3 or type 4. So I'm just going to talk first about Rick's first presentation. So that's the heart failure, secondary worsening of the kidney disease. And we can, and Jeff's going to talk a lot about the pathophysiology of this, so I'm not going to go into this in great detail. But essentially, we can see that heart disease leads to decreased cardiac output, which affects the kidneys. The kidneys turn on renin and angiotensin and all the things that they're supposed to turn on in the face of low flow, vasoconstriction, salt and water retention, and then that has a negative impact on heart function. And then you go through this downward cycle where both the heart and the kidney function are deteriorating. And here's it in a little more detail, and I'm not going to go through this in any detail, but basically you can think of there's common risk factors for both heart and kidney disease, and this is going to kind of come up over and over again. There's certain things like diabetes, high blood pressure that affect both the heart and the kidneys, so that's going to have an effect on the kidneys and the heart. And then in the setting of an acute heart failure, you have two things. So you may have low flow to the kidneys, or you may have venous congestion of the kidneys. And it's actually two fairly separate issues. If you have low flow to the kidneys and you start to use diuretics to get rid of fluid volume, the kidney function tends to get worse. If you have venous congestion of the kidneys and you use diuretics, then often the kidney function can improve. So you can see it going both ways depending on what the actual etiology of the kidney failure is in the setting of heart failure. And then a lot of things that we do to patients, medications like diuretics and ACE inhibitors, can acutely worsen the kidney disease when we're trying to improve the heart disease. So we end up with this Scylla and Charybdis. This is my Greek reference at this point. This is the only thoughtful thing I've come up with for the whole talk. So this is the Scylla and Charybdis of renal failure. I actually stole it from somebody else. I stole it from this guy here. But basically, this is from Greek mythology, and Odysseus had to pass through the straits, and they're the straits between Sicily and Italy. And on the left side, Scylla is a Greek creature which has multiple stones sticking out of the water, and it eats sailors. And on the other side is a whirlpool, and that's Charybdis, and he has to make his way through. He loses some of the sailors to Scylla, but he avoids going down through the whirlpool. And this is what you kind of think of with heart failure and renal failure in this situation, because they have heart failure, and as Rick pointed out, he had fluid on his lungs. So we want to try and get rid of the fluid. We want to give medications that offload the heart to try and improve heart function, and all of those things can make the kidney failure worse. So then the kidney failure is getting worse, so then we back off and we stop those medications, and then we end up with more heart failure. So we're always balanced between these two things, and Rick had the best outcome in that somebody came along and fixed his heart. And if we can do that, then that is an optimal outcome because that relieves all the problems. If we can't do that, then we're stuck in this situation. So just some of the epidemiology. This is an interesting paper that is actually a review article, and they found 8 different epidemiologic observational studies that just looked at outcomes of patients who came into hospital with acute heart failure. And this is just showing the outcome as far as mortality. So Rick, you might want to cover your ears at this point. So they divide into 3 different classes, but basically this was about a 5 mil per minute decline in renal function, 10 and 15 mil per minute decline in renal function. And you can see the mortality associated with that. So if they came into hospital with heart failure and you had a 30 milliliter per minute decline in your renal function, you had a 3.2 relative risk of dying during that hospitalization. And I just threw up Rick's early changes in renal function, and he had at least that amount of decline in his renal function. So he was down in this area here. So walking into hospital, with heart failure and underlying kidney disease, and the sudden worsening of the kidney disease puts you at a 3-fold increased risk of not making it out of hospital. So there, made it through that one. And this just shows, this is from the same study, same meta-analysis, that your risk of having an acute change in the renal function is dependent on your baseline renal function. So these are American units, but down here, 2 is about 160, 170 micromoles per liter of creatinine, and you can see that puts you at somewhere between 30 and 40% risk of having acute renal failure if you walk into a hospital with pre-existing kidney disease, which Rick had. So it's not surprising he developed this thing. And the other thing is that risk of mortality declines with time. So if you go out to 6 months, 9 months after your initial presentation with heart failure, your risk of mortality goes down, but you can see it certainly doesn't go back down to zero. And this is a logarithmic scale, so the risk persists. So I'm going to switch and just talk a little bit about type 2 cardiorenal syndrome. So these are patients with chronic heart disease who have underlying kidney disease. And this is really that Skyline Charybdis thing, because now you have time to really play with these patients and increase the diuretics, decrease the diuretics, try and attempt different things to improve them. And this is a large epidemiologic observational study out of Edmonton. And what they looked at is they went to their heart failure clinic, and McMaster has a similar, or the General has a similar heart failure clinic. So they went to this clinic and they just looked at people and they categorized them based on their underlying renal function. Up at the top there you can see the different classes of renal function. So this is patients with the worst type of renal function up to the best type. And then they looked at a whole bunch of, and I have to get my glasses out for this, they looked at a whole bunch of different characteristics of these patients. And if you go down the list here, the interesting thing is right at the top here, you can see that patients who have the worst renal function also tend to have the worst heart function. This is as according to the New York Heart Association classification of heart failure. And then if we go further down the list, the patients who have the worst renal function actually have better better left ventricular function. And that's probably a survival benefit. If you have really poor left ventricular function and poor renal function, you're not going to survive long enough to get into this particular study. And then further down the list, the really interesting thing is the medications. So people with the worst renal function here are least likely to be given ACE inhibitors, which we know improve cardiac function, least likely to be given beta blockers, which we know improve cardiac function and outcome, spironolactone associated with better outcome in heart failure. So all of these medications that we know really help people with heart failure, we're not giving to patients with the worst renal function, probably again because of this problem that if you give it to them, their renal function gets even worse. And then this is the key critical thing, is that depending on your renal function, if you have pre-existing chronic heart failure, these are the types of outcomes. So if you have very poor renal function, this is a 1,000-day follow-up survival is about 40%. So not very good outcomes, and probably these types of patients have probably poorer outcomes than patients with bowel cancer or something like that. So if you walk into the hospital, if you are going to a heart failure clinic and they tell you have renal dysfunction, you ask them if perhaps you could have bowel cancer instead, because your outcome will probably be better. And these are just some of the multivariable predictors of mortality within that patient population. And again, you can see, obviously the worse your heart function, the worse you're going to do, and et cetera down the list. And if you're able to tolerate some of these medications that we know are beneficial, your outcomes are going to be even better. So how do we treat this, both in Rick's case, this type 1 cardiorenal syndrome, and the more chronic case? Well, anything we can do to improve the cardiac function should improve outcome. And that's what I was saying that happened in Rick's case. They surgically went in, fixed the heart, we had a better outcome. But whenever we try and use medications, we often run into the problem of worsening renal function. I put down here novel therapies. I'm not a heart doctor, but I think there's things coming along, left ventricular assist devices and things like that that may one day be helpful. And then finally, what we get asked by our cardiology colleagues all the time is maybe we can do dialysis. Because the main problem is we're using diuretics to get the fluid off, and that's making the renal function worse. Why don't we just take the renal function right out of the equation and put the patients on dialysis? So I'm just going to go over that very briefly. So the question is, can we use some form of ultrafiltration, which is hooking somebody up to a blood dialysis or hemodialysis machine when they're in an acute situation like Rick was in, and perhaps we should put people on chronic type of therapy if they have chronic renal failure in the setting of chronic heart failure. So here's a trial that came out in 2007, and there's actually a more recent trial that was just published in the New England Journal last year. And the idea is you walk into the hospital with heart failure like Rick did, your kidneys aren't working well. Instead of just pumping these guys full of diuretics to get the fluid off. Why don't we actually hook them up to a dialysis machine and get the fluid off this way? So they actually randomized about 200 patients either to get ultrafiltration or just standard care, which is diuretics. And you can see here that the weight loss was much higher in the patients who got the ultrafiltration, so they lost more fluid than just with the regular diuretics. Their kidney function was exactly the same in both groups. And the big outcome from this trial was that the patients who got ultrafiltration were significantly less likely to show up back in hospital within 90 days. So no mortality benefit, you didn't live longer, you got more fluid off with the ultrafiltration, and it kept you out of hospital a little bit longer. So this type of therapy keeps getting kicked around, and we keep getting asked to perform this ultrafiltration in patients. But the evidence is fairly poor. The New England Journal paper that came out was even less promising than this, that if you optimize diuretic therapy, you could find that you could get similar results than with ultrafiltration. So the other question that comes up is, for the more chronic situation, could we put people on dialysis? And there's not very much evidence for chronic hemodialysis. There's an interest in peritoneal dialysis in this setting, and that's what we've put, or what Rick has agreed to go on. So peritoneal dialysis is a more chronic form of dialysis. We use the peritoneal membrane in the abdomen. Fluid is put in there and removed on a regular basis, and there's slow, continuous ultrafiltration. And theoretically, it should be a good treatment. We have very little evidence for using it in patients with heart failure. This is from a review paper, and you can just see they've just listed all the different studies that have been done, very small number of patients, not randomized, and what they suggest is that there is overall some improvement in symptom scores. So this is a New York Heart Association classification, sort of going from 4, which is shorter breath at rest, to 2, which is shorter breath with some exertion, and some reduction in rehospitalization. So it certainly looks hopeful, but there's no randomized trial. I did dig up one randomized trial here. So this was published in a very prominent journal, the Review Experimental Cardiology. So clearly there's some problems with this particular study, but in fact it came out of Spain, and what they did was they took all their patients with heart failure and they offered them peritoneal dialysis as a treatment for the chronic heart failure, and 28 of their patients agreed to go into the study, got a peritoneal dialysis tube, and were initiated on peritoneal dialysis. The other 34 patients that said, bugger you, I'm not going to go through that, they're in this line over here. So it's not really a randomized trial, it's a trial of patients that agreed to the treatment that didn't. But saying all that, they did find a mortality benefit in the patients who ended up on peritoneal dialysis. This clearly needs better randomized trials to see if we can do this. But the idea is you're eliminating the kidneys from the problem. So instead of always trying to balance the diuretics and the and treatment for the heart failure and worried about the kidney function, just take the kidneys out of it. We'll do dialysis and worry about treating the heart failure. As I showed you, the patients who had the worst kidney disease tended not to get the best medications for their heart disease. So the hope is that if we can get rid of the kidneys from the equation, we can put them on all the best medications. So just a couple of slides about type 4 chronic renal cardiorenal syndrome. And this is really the renal-cardiac syndrome. So this is patients with chronic kidney disease, which Rick now has, who had developed aggressive heart disease. And this is very common. And this is from an excellent review article in Lancet that just came out. This fellow is Dutch, but a couple of colleagues of ours from Edmonton are co-authors on this, including Brenda Hemmelgarn, who actually trained here at McMaster and is now out in Edmonton. But basically what they're showing you, as your kidney function goes down, your risk of developing coronary artery disease and cardiac disease goes up quite significantly. So at very low levels of kidney function, your risk of cardiac disease is about 3 times baseline. And there's also an increased risk of cardiac disease simply with proteinuria or albuminuria. And this just shows, these are survival curves. So this is how much longer you're going to live at each of these ages. And let's pick 50 years old here. So if you have normal renal function, your life expectancy at 50 is another 25 years. If you have very low levels of renal function, your life expectancy is down around 5 to 10 years. And Rick, you might want to cover your ears up for this, but you already escaped the first little one, so we're going to get you through all this. You need to have a transplant, and then all these risks change dramatically. So I'm not going to go into this in detail because I think Jeff's going to talk about this, but again, there's all these common risk factors that affect both the kidney and the heart, and then as the kidney function declines, there's a whole bunch of novel factors that come up, including calcium and phosphorus, chronic inflammation, which come about because of the kidney disease and then go on to affect how the heart functions. So we start with the common, well-known risk factors, and we go into some really odd and unusual things as the kidney function declines. Within that review article, they had a whole bunch of therapies, and the interesting thing is, when you look at all the huge randomized clinical trials of patients with heart disease, coronary artery disease, and what to treat them, the inclusion criteria, they get rid of all of our patients. So anybody with kidney disease, they get rid of. So we really have very little idea of how best to treat somebody with chronic advanced kidney disease or somebody on dialysis if they have underlying heart disease. So dietary, smoking cessation, is definitely, even though there's no randomized controlled trial evidence for this, it's definitely a good idea. And then there's a whole bunch of other lifestyle things that we can do that really have very little evidence, and dietary sodium restriction is still very controversial, but probably important, especially in our patients who are on dialysis. They have to restrict sodium. And then as far as pharmacotherapy, again, all these things are well known and well documented in the normal population. We just don't have a lot of good evidence for it when you get to patients with chronic kidney disease. And things like blood pressure reduction, it's not clear what levels of blood pressure we should target in our patients with chronic kidney disease. Simple things like Ramipril, which we know is very effective in patients with heart disease and at risk for atherosclerotic disease. There's no studies in patients on dialysis with this. There's some evidence for lipid control. There's a recent very large randomized control trial with about 30,000 patients that did show some benefit. So I think being on atorvastatin is a good drug of choice. Antiplatelet therapy, when you get into antiplatelet therapy and anticoagulation, the rules all change in our patients with chronic kidney disease because they bleed a lot more. So whereas there's always a risk benefit in the normal population, as soon as you double the risk of bleeding, the risk benefit tends to disappear. So we're never sure whether our patients should be on aspirin or warfarin or drugs like that. And then there's a whole bunch of other things that are specific for patients with chronic kidney disease, which really have zero evidence at all associated with them. So just to summarize, this cardiorenal syndrome thing is really a big spectrum of diseases, all the way from people with heart failure who develop kidney dysfunction to patients with kidney failure who develop heart problems, and anywhere in between those two. And those are the two extremes, are really the heart failure and the kidney failure. And these are very common complications. So somebody who shows up in hospital with heart failure, they're at high risk of developing kidney disease, and our patients on dialysis, for instance, with very much decreased kidney function, they are at very high risk of developing heart disease. So the acute kidney failure in the setting of acute renal failure in the setting of acute heart disease is really the treatment option is sort of this balancing of trying to treat the heart disease while not spilling the kidneys into failure. And really, we're still at early days, but there's still some hope. Things like peritoneal dialysis in a chronic setting may, in fact, prove to be useful in the end. And then the other end of the spectrum, the sort of patients who develop heart disease in the setting of kidney disease, this is related to a lot of common risk factors, and Jeff's going to go into more detail about this, but there's also some other interesting novel risk factors associated with kidney disease. And I'm going to end by saying this is an area that needs further study, and Jeff needs to get more CIHR grants so he can keep studying this in the future. And I wouldn't mind a few as well. So I'm going to stop there, and if anybody has any last questions from a clinical perspective for Rick about what he's been through, he can answer them now. And if not, maybe we'll get Jeff to stand up, and then we can do answers to everybody at the end. Does that sound fair?